10 years now. And he has changed quite a bit, and so have I. But he's still, for me, like the greatest oral surgeon that I've seen. He's by training both a DO and a dentist. He went to dentistry school, finished dentistry school, and then went on to do another 4 or 5 years of DO school. So he's one of those few guys who has gone for the long run, and he's never really stopped. And I personally have watched a lot of people, a lot of different dentists in Germany, Carmel, Turk, all the guys, all the big shots, surgery people in the jaw. I've never seen a surgeon that has done the work so beautifully as Chris does. And Chris is a very creative thinker aside from being a great surgeon. And he's always been out there looking for ways of improving the outcome and helping the patient with in various ways, always combining, conventional medical allopathic treatments that work with the best of the alternative stuff that's around. And so every time I've heard Chris speak, he has definite blue pearls that all of us can apply and that are important. Usually, I've known Chris for 10 years, and usually he's always been 5, 6, 7 years ahead of everybody else. And usually the pearls that he's given have always turned out to be true years down the road. So, no more words, Chris, you're on.
Colleague for the great introduction, and don't believe any of it. I gave him $20 to say that. So,
could you turn the mic on, please?
We have a lot to discuss. Some of you have been to some of my lectures before, and some of this will be review for you. And if you're bored, that's too bad. Just live with it. One of the things we've been talking about, one of the pearls, is always protect yourself when you're doing medicine or dentistry. Protect you and the patient. So what I've been doing now is I wear a condom and my patient wears a condom. And I'm not sure if it's working or not, but I feel protected. So I'm not sure if that's what that means or not. But on a serious note, I have a little 5-minute picture of a woman who had multiple sclerosis for many years. I saw her back in '91.
Can't hold that mic.
The film I want to show you is of a very special patient who saw me in '91 with a diagnosis of MS for approximately 20 years. She had a lot of peripheral paresthesias and pain, and she just made this little film for me. I think it's just nice that you see this, saying that the work that we're doing does actually help these patients. So we could roll this video. It's a short video. Then I have about a slide and a half carousel we'll go over, and then I'll answer any questions. Go ahead and roll the video. Can you turn up the volume? Well, then, we'll forget it then.
Put the mic in front.
Can you use the microphone on it? You want this mic? Let's forget it then. Unless they can hear it. If everybody really quiets down, you can hear it. Why don't we turn off the ozone machines?
mostly peripheral vision and eventually total vision. The solution to that was cortisone. It seemed to fix almost anything. And 10 days and it was gone. But nothing ever relieved the pain. In early 1990, I started going to an MS clinic in downtown Detroit. I spent about 2 years there. And by the time I found Dr. Hussar in late 1991, I was living with quite a bit of pain, 250 milligrams of naproxen every 3 to 4 hours. I had no bladder control, so I used a catheter 5 times a day. I had no bowel control, so I had to do enemas 3 times a week or have colonics done. I prefer the colonics because they were less abrasive. I took Ditropan to calm the bladder. I was on Elavil at night. I didn't like Elavil. But that was basically the way I was functioning day to day. My last and final visit at the MS clinic, Dr. Elias told me to accept the fact that I had MS, get into a wheelchair, quit my job, and go on disability. Just accept it. There wasn't anything I could do to stop the downhill progression that I was taking. Being the fighter that I am, that was the last time Dr. Elias or anybody else at the MS clinic ever saw me again. Now, I found Dr. Hussar through the recommendation of a colleague that I worked with. He said Dr. Hussar gets real good results with MS patients. Obviously, he does. When I saw Dr. Hussar, I had to get help getting up on the examining table. I couldn't bend over to reach my purse or anything. I never put my purse on the floor because I would never be able to pick it up. I was in a lot of pain, and I shook like I had Parkinson's. My hands shook, my head shook. When I would drive, I would push my head against the headrest to try and stop the shaking, and I couldn't. What Dr. Hussar did for me at that time was inject the 4 areas of my wisdom teeth and this front incisor with Procaine. And I'm not always real familiar with the medicines he used or necessarily why he was doing it, but it didn't matter who the doctor was I was seeing. I did everything they told me to do. And in this case, even though I was extremely skeptical after the last doctors I had seen, I allowed him to do these injections. And within 30 seconds, the shaking had stopped. And this had been going on for more than a year. All the shaking had stopped. And though I didn't notice the pain going away until I got up. Once I got up, I stood straight for the first time in almost 2 years. And I can remember walking down the hall in his office and absolutely feeling no pain. I bent over and touched the floor, touched my shoes for the first time in 2 years. Couldn't believe it. How in less than a minute could somebody get rid of the pain I had lived with for almost 20 years? I was 34 years old when I found Dr. Hussar. And I had had this pain since I was 14, progressively getting worse year after year after year. He got rid of the pain. And needless to say, as soon as that Procaine wore off, the pain was very bad. Maybe my perception made it worse after not having it for a while. But I knew that whatever it took to get rid of that pain again, I was going to do. And that meant oral surgeries, taking out the infection in every area he suspected in my jaw where there would be an infection. Now, I can't tell you the details of what he does or doesn't do. What I do know that is after every surgery, even before the surgeries, when he froze that area, that pain and that dysfunction disappeared and it never came back. I used to fall down all the time. I haven't fallen since April of 1992, but I would be walking down the hall and out of the clear blue, be walking down the hall talking to a colleague, and from the waist down, everything would shut off, like somebody hit a light switch, and I would be on the floor. There wasn't any warning, no sharp pain, nothing, and I would be on the floor. I could get up in a minute or so. I would get the strength back and I could get up, but there was never any warning. When Dr. Hussar fixed this area in my mouth and took out the infection here, I never fell again. That surgery took care of it. This area of my face, I took a softball to line drive right to the face, and though it was checked for problems with the teeth, nothing showed up, and we corrected problems with the TMJ that resulted from that. But it was Dr. LaCharity, when he was doing x-rays, that found this infection here and sent me back to Dr. Hussar to look at this, and that was the area that fixed the problems with my falling. I can take my medical records and map my dental records over the top of them, and in every instance show a correlation between something that happened in my dental history and a follow-up problem in my medical history. When I was 6 years old, I lost the front incisor. I snapped it off. That tooth abscessed, and they eventually pulled it. By the time Dr. Hussar got to me, most of this upper palate was infected. It took 3 surgeries to get this infection out, but now I'm confident it's all gone. The problems that I experienced with the bladder and with the bowels, well, at least I know the bladder, were definitely tied to this area in the mouth. I lost quite a few teeth, obviously. These are fake, these are gone, and some in here. But that was a small price to pay for not having the amount of pain and dysfunction that I had. When I was 12, I had 12 fillings put in, and I'll never forget that because my parents didn't have the insurance. This stays in my mind. By the time I was 13, I started having the neurological problems. When I was 15, the wisdom teeth came out. All of them, 2 of them abscessed, and they pulled all 4. By the time I was 16, I spent 3 weeks in the hospital with seizures. No idea what was wrong. They did spinal taps, a zillion and one tests. They found a protein in the spinal fluid. Gave me cortisone, 10 days, and it was gone after 3 weeks in the hospital. But that just continued on, and no correlation or correction to anything that was happening. But it wasn't until early 1990 that I took this severe downhill slide. April of 1990 is when I had this accident in the front jaw here. And from that point on, I went downhill until, of course, I found Dr. Hussar. And that's pretty much what has happened in the course of the last 2 to 3 years. I tested positive a number of times for Lyme disease. We did treat me for Lyme. I'm not convinced that it is or isn't there. I don't know. What I do know is I have no more pain. I have no more dysfunction. And that is the one thing in all the years and all the medical treatment that I had done, the only thing that made the biggest difference for me was that Dr. Hussar was the only one who could get rid of the pain. No matter what kind of treatment I had or what kind of tests I had or what kind of drugs I had, I never lived without the pain until that day when he first froze this and then subsequently took out those infections, and it has never come back. So that's pretty much where I've come from and where I've been, and I'm sure Dr. Hussar can give you all the medical.
Interesting, we have a number of things going on with this patient. We have a demyelinating syndrome. No, that's enough. That's just showing me doing some neurotherapy. We have a number of things with this patient. Interesting, we have a demyelinating syndrome. Since I didn't touch the mercury first, I took out the 3rd molars. This is probably where the demyelination came from. And Jerry talked about this. She had aches and pains all over her body that would basically be variable. It would be one place then another. She had peripheral neuropathies, bilateral, lower extremities. She had a history of multiple dental procedures and trauma to the face, root canals, struck in the face. And this was about 7 years ago. I worked on this patient, knowing not half the things that I know now, and I got great results with this. Unfortunately, I don't get this, and you know all the same that you don't get cures in everybody, but this is what a dramatic case. And I just wanted to explain it to you, showing the dramatic nature of this work, and it makes you a hero at times and what you can do. That's all I have to say. Any other questions? No, just kidding. Slides, please.
You find a lot of results with numbers of multiple sclerosis.
It depends. I've had great results and not so great results. If they're really chronic, and there's sometimes there's not a lot you can do for them. You know, what causes demyelination? Mercury, heavy metals, chronic infections. So at least you have to start there. And every MS patient, I feel, should be checked for Lyme's disease. Because I think most, or I would say half of all MS patients are undiagnosed Lyme's disease. Unfortunately, Lyme's disease testing, the serum testing is not very good. I use a lab in California. They do a Lyme's urine antigen test. And that's probably what you should consider on most of your patients with this, because you want a polymerized chain reaction Lyme's urine antigen test that's challenged for 4 or 5 days at least with some type of antibiotic therapy to get some die-off of the bug that will show up in the urine. Now, I'm not giving a lecture on MS, but any pearls I can pass on. I tend to like the generic term cavitations, and I reserve the NICO term for patients who do have true neuralgias. Only those who attempt the absurd achieve the impossible. Oh, sure, you're going to take out a root canal and cure my cancer, right? Or you're going to cure my MS by cleaning out infections in my jaw? Sure, right. Well, I've seen it. Okay, now this is Jerry's term, neuralgia-inducing cavitational osteonecrosis. Alternative NICO names: trigger point bone cavities, jawbone cavities, osteocavitations. The term that Dr. Ratner coined, alveolar cavitational osteopathosis, or ACOs, and the Ratner-Roberts cavity. The cavitation is a lesion is a chronic infective process involving the dental alveoli, the upper and lower jaws, and it's very similar to an osteomyelitis in a distant bony segment. They vary in size, are hollow in nature, and are housed in the cancellous bone. And we talked about earlier how difficult they are to see. That's not really true. The more you get to visualize these things on X-ray, then open up the jawbone and you get to see the extent of them clinically, and you go back to the X-ray and go, oh, I can see that now. I can see where the bone is destroyed. This is a landmark article by Dr. Ratner, Manifestations of an Infectious Process and its Implication in the Causation of Chronic Pain. In this article, he talked about patients with intractable neuralgias of face and jaws and of the periphery, and some of his work in the successful cases cleaning out chronic infections in jaw bones. They cause cure of neuralgias elsewhere. Pardon me? I think it was a Journal of Periodontology, 1978. It's in Jerry's handout, so it'll be listed in your pamphlet of stuff. Dr. Ratner is, and he's written several articles. He's an exodontist in Brooklyn, and apparently his office is like the first 3 letters of his last name, but he's a very interesting and unusual man. Old subject, sure. This is a 1922 article from a dental journal in Canada talking about residual osteitis as a result of extractions of teeth. This is an article by Dr. Box, and Dr. Arana told me about these guys many years ago. He did some research on them, and they were dentists in the Toronto area, 2 brothers that did probably in excess of 15,000 surgical procedures on these chronic infections. And they also were aware of the diagnostic and neural therapy, if you will, of diagnosing these lesions with doing nerve blocks or injecting local anesthetics. So if you see the name Box come up, they're basically heroes in this business, and they go back 40, 50 years. NICO lookalikes: aseptic ischemic osteonecrosis, corticosteroid-induced osteonecrosis, and so on and so forth. You know where I got this slide, so. What type of symptoms do you see from these cavitations? Well, if it has neuralgias, you'll see atypical facial neuralgia and pain, trigeminal neuralgia, headache, TMJ pain. How many patients have you seen in your office who have had splints made by other people that never did them any good? In reality, it was a cavitation promoting their pain disorder. Chronic fatigue. This is most of my patients, either chronic fatigue or atypical facial pain. I see very few of this, but these are basically gradients thereof. This is the most severe one, and this is not quite as severe, more milder case, if you will. On my insurance billing, or if I do my super bill, I usually list this. along with chronic alveolar osteomyelitis or osteonecrosis. This is an article written by an oral pathologist on a study done on chronic fatigue patients, and 85% of them had some type of symptomatology of the head and neck region. I'm not going to have you list that, but 85% had symptoms of the head and neck, which included facial pain, tinnitus, eye problems, otalgia, neck pain, jaw pain. Now, since this is I'm trying to show you how these things affect both local and distal problems. We're talking about focal disease here, and it's been mentioned before in several different lectures. A focus is a pathological local change in soft connective tissue producing a material which cannot be broken down so that the local and general systems of resistance are in permanent active reaction against us. I think Dr. Haley will talk about this more tomorrow. As the local resistant barriers start breaking down due to the endogenous or exogenous factors, red toxins, the focus begins to exert an influence over remote parts of the organism, thus triggering a general focal infection, which is always of a chronic character. In my practice, the head is the major center of focal infection, especially in the upper and lower jaws. Other areas, for those of you who are physicians that work elsewhere, you get to think about chronic appendicitis scars, cholecystitis scars, bacteria in the bowel or elsewhere, or chronic infections, mycoplasma infections, Gulf War syndrome infections, scars, cicatrix, chronic inflammatory reactions. Chronic inflammatory processes usually will proceed to tissue destruction. My patients are catabolic. They have no muscle mass. They have no energy. They're literally wasting away. And they'll tell you, doctor, I've lost 20, 30 pounds in the last couple months and I'm eating. They don't eat very well or they eat the wrong foods. A lot of times people think that vegetarianism is the right way to go for this disease. And that's not true all the time. They need protein. They need muscle mass. They have no immune system left. Part of the destructive products are stored permanently stored in the mesenchymal tissue, such as thioethers and mercaptans. And that's what we find inside root canals and cavitations. The mercaptans means mercury holding, capture mercury, mercaptans. Another negative effect of this disintegration may be found as an allergic reaction of the delayed type. Effects such as inflammation frequently occur in the region of the teeth and jaws and are often the result of iatrogenic damage. The principal causes are faulty dental extractions with apical residues or extractions in which inflamed surrounding tissue has been left in the dental alveolus. Every wisdom tooth is infected. Every wisdom tooth I've ever taken out, I don't care if it's full bony, partial bony, flap, whatever, there's always a low-grade or a full-blown infection around it. And the older the patient, the more they have a impacted wisdom tooth in there, you're going to find more neco-lesions associated with those things. The bone is always ischemic, and it will always be infected with some type of osteomyelitis. There's no such thing as a good wisdom tooth in my practice. And if you start biopsying the teeth and the surrounding bone, you will see that. And in my opinion, dry sockets are not a result of the patient losing the clot. It's not recognizing that the bone is infected and not curetting the bone out and not disinfecting it and not sewing it up. Because I might get 1 or 2 dry sockets a year, and if you saw what I do, you'd think I would get 1,000 of them. But if you curette out a third molar extraction, you won't get dry sockets. I guarantee it. Histopathological analysis of a typical lesion finds fibrous connective tissue, Jerry talked about that, and spicules of bone, both fresh and necrotic, viable and necrotic. And I see this all the time. They look like huge snowflakes, if you will. They're fragmented lesions. They have like branches that go off, and the body's trying to grow new bone, but it can't. So it can grow certain areas of bone in one areas, and where there's more ischemia in other areas, it can't grow anything at all, and there's a void there, a cavitation. Microbiological studies reveal a mixed polymicrobial aerobic and anaerobic flora. This is your major thing, anaerobes. This is very variable, however, in that common oral pathogens may be found on one occasion, while other histological specimens reveal organisms that are foreign to the oral cavity. Commonly, anaerobic organisms occupying the gingival tissues are found in these lesions. There was a recent study done showing what are the common organisms that are found in the bloodstream after periodontal, endodontal, or oral surgical procedures done. There's Propionobacterium, Strep sanguinus and intermedius, Fusobacterium, Saccharomyces, Actinomyces. Eikenella corrodens, which is implicated in causing sclerosing osteomyelitis. Herpes simplex, herpes simplex, that's a misspelling. I should get my money back on that slide. Parasites, Dr. Wannarada talked about that earlier. And candida. Now, I'm doing some research now, and I have a lab that's going to try to do these things for me because I'm sure they're there. Because I've seen people with chronic recurrent herpes infections get better after cleaning these wisdom teeth out. And I think that these chronic inflammatory reactions are holding sites, if you will, for the common pathogens, both viral, bacterial, fungal, and parasitic. In short, 150 microbial species have been identified in apical periodontal lesions, 350 species in marginal periodontitis. How do you diagnose cavitations? Take a thorough history. Have you had a dry socket in the past? When did the pain begin? Was your pain or any of your problems associated with some kind of dental work? Was it precipitated by a root canal or dental work? X-ray. I pretty much use panoral X-rays and periapical X-rays. The point that Dr. Bocot made earlier was if you can visualize the inferior alveolar canal, that's great. If you see destruction, then you know you have a large lesion you have to contend with. You see socket outlines, you see laminar rain. Microcalcifications, these are called rat's nest. Whenever you have an inflammatory area in your body, whether it's a breast or the jawbone, for example, the body likes to lay down small little microcalcifications. If you see those on your X-ray, you know you have a NICO or cavitational lesion. Digital imaging, I'm going to show you some overheads after this showing a new type of technology that come out. Bob Jones has invented it, and it might be useful in diagnosing cavitations for us. The Tech 99 bone scans were mentioned earlier, and the computerized scintigraphy might be a way to go for these things. This is probably the easiest, simplest to get. Unfortunately, 50% of your films will be negative because, number one, the radiologist doesn't know how to read it or reads it as periodontal disease, or you have no bone flow and no active metabolic bone to indicate that you have a positive bone scan. Thermography. This is temperature imaging using radiant energy of hot and cold spots. Here's a crude thermogram I used years ago, and this was a hot spot on a patient who had neuralgia in her left arm and a cavitation, a large cavitation in the left maxillary tuberosity, which we cleaned out. It was a very simple procedure, and her neuralgia in her arm went away. This is the temperature gradient. This is white-hot, being high temperature, and this is blue or dark. Now, just because you have a cavitation doesn't mean it has to be hot and inflamed. You can have dead bone and have cold faces on the jaw. If you have patients with reflex sympathetic dystrophy of the face, you will have cold lesions on the face. When I say cold lesions, that means per thermographic evaluation. More diagnosis. Do a physical exam. Ask them if they have pain anywhere else. Do they have rheumatological problems? Most of your patients with cavitations or NICOs will have some other disease process someplace else. They'll have chronic low back pain. Wisdom teeth and cavitations cause chronic low back pain all the time. Peripheral neuropathies. The movie of the woman I showed you, she had peripheral neuropathy from third molar cavitations. Always remember to do your neural therapy. And that's what the patient was describing to you, using local anesthetic without vasoconstrictor, use a small syringe, and do your little diagnostic injections and ask the patient how they feel either immediately or over the next 8 to 12 hours. Send them home, say, I want you to keep a written diary for me. So when you come back in tomorrow, you're going to have that written down for me. You're going to tell me how you feel. And you put that in your chart for documentation. Always do your nerve blocks. This is what lawyers love to pick on dentists for. This is accepted. Dr. Klinghardt is the best in the world at doing neural therapy. Please do neural therapy. You don't have to list it as neural therapy. You'd list it as a diagnostic nerve block in your chart. Put down how much local you use and what kind of needle you used. Please don't use vasoconstrictors. If there's one common denominator here why we all have cavitations is because we all get mercury fillings, we all get fluoride on our teeth, and I'm sure there's some chemical association with fluoride and mercury. I haven't proven it yet, but we all get multiple dental procedures, and we always get a little vasoconstrictor in the shot. How many still use vasoconstrictors here as dentists? Okay. I really don't think you should do that because you have an end arterial supply here, and every time you inject, you shut down that supply a little bit more, and a little bit more, and a little bit more. And that's why you get pulpitis after you do injections on a tooth that's questionable to begin with. I don't have any of my patients have any dental work done for up to 6 months or more after the procedure, except for maybe partial or impressions for partial dentures. I don't want anything disturbed when I do this work. Yes?
When you give your injection, like with that MS patient, that relief of symptoms, let's say now that lasts for 2 to 4 minutes, not even more than that.
Severity of the cavitation. Okay, if you have a lower lesion, let's say a mandibular lesion that has destruction of the canal, you've got yourself a handful. I don't know how many cavitations you've done, but I'd like to have $1 for every one I've been inside of a lower molar cavitation, third molar. The patient is consciously sedated. I have them with Valium or Brevital or Valium and Demerol or Valium and ketamine. They are blocked like you can't believe, and they are still screaming for my work. That is focal disease. That's an electrical disturbance because of the chronicity of these things. How many times you do a procedure on a crown and the patient's blocked, they feel they're blocked where they're supposed to be. You know, you've got your block, and they're still feeling your work. It happens to you every day, doesn't it? Because you have a cavitation behind it. That's why that nerve is so inflamed, you're not going to be able to get it to sleep completely. And the only way to get it to sleep is to clean out the area around it. And I use it as a tool to my patients. I say, look, you have a severe lesion here. You might be feeling some of this, but you know what? When I know you're not hurting anymore, I know I got the entire cavitation out.
But what I'm saying, when you're using it for diagnosis, if, like in Hunnicky said, you want to see it last for, say, 8, 10, 12 hours.
Right.
So if you get a result,
Bless
like
you.
a dramatic result, like with the MS patient, but it doesn't last
Right.
more than a few minutes, 3, 4, 5 minutes, you're saying it's because of the severity?
One thing, but you got to look for focal disease elsewhere too. They could have an infection someplace else. They could have scars. They could have heavy metals.
But the fact that you got some result shows
You know you got something there, so the patient's in your office, you got to start somewhere. Dieter, do you have anything to say on that?
Yeah, don't quote the Monicas. That was 30 years ago. We were having medicine this says if it doesn't last 4 hours or longer, simply means what we can say is that there's one or several other factors of our organism. And however, if there's any pain relief use of medicine, this area is a problem. This is the string problem. One of the what needs to be changed. So you can start there. Remember that all this work your therapy is to clean up the patient, and the mouth is a big portion of it, so it's not the only one. So let's communicate that it's not.
The other point I want to bring up here is you'll see patients, for example, taking what you mentioned. You've done your block on the side that the patient is symptomatic, let's say. You know, they come in, they present with facial pain. Go to the other side, the contralateral side, and block them there. And if that gets them number, then you know you have other cavitations to do. And I've had several patients who I cured facial pain on the right side by doing a cavitation over here. There's only one nerve that innervates this. That's cranial nerve number 5. And if that has 2 or 3 root canals, 3 or 4 cavitations, and a toxic load of mercury, there's a lot of work to do before that nerve's going to say, oh, okay, I'm better now. 10 to 15% of your patients, I would guess at that, I would say 10% won't get better until you get all your cavitations out. Some will get better just doing the one area that's bothering them, and they'll say, Doc, that's enough, and you know the other ones, and I tell them that. I say, Doc, I'll come back when I'm ready, or let's go for more. Okay? So that's another reason why you might not get the numbness that you want. Kinesiology. Now, Dieter is a master at this, and a lot of you do this. A lot of you like the EAB testing. I like the EAB. I used it years ago. Uncle Sam doesn't like that, and Uncle Sam likes to look over people's shoulder doing things like that. And in my state, it's even legal, but Uncle Sam has more power than the state board. So I stay away from electrical machines. I think they're great in the right hands. I think they should be used by people of medical or dental background. That's how I feel. EAV, dermal testing, of course. Ultrasound. I'm going to show you some slides. Jerry showed you one slide on the pig jaw that was diagnosed. The cavitation was diagnosed with ultrasound energy. And always listen to the patient. They'll give you the answer. Say, Doc, all my problems started when I had a root canal over here. Root canal didn't work. Took the root canal out. Still had pain. Always think that there's a problem in that area and a problem behind it in the wisdom tooth. Bone scan. You saw this already. Now, one way you don't diagnose these, you don't start doing serial root canals. Oh, that didn't do it, let's do another one. That didn't do it, let's do another one. And the problem here is these patients really, really like their general dentist or the endodontist that did this work. And I'm going, son of a, you know. These are just part of it. This guy had root canals all over. He had 15 root canals, and I've had 4 or 5 cases of x-ray sent to me. Doctor, I give up. Would you take a look at this patient and see what it was? And their problem started back in the 3rd molar cavitation. If somebody had cleaned that out, they wouldn't have all the root canals. Now, this is a patient, one of my worst patients. I think I've taken out these. He's edentulous on the bottom. I have to take out the anterior teeth. He isn't ready for that yet. I've given him more anesthetic, general, and he still feels the pain. He's blocked and blocked and blocked. I've taken my little Stabident procedure and gone into the bone and blocked him. He still feels it. He breaks out in a cold autonomic sweat when I work on him. I cannot get him blocked. These infections are so severe. He's on IV antibiotics, oral antibiotics. He is a mess. He's slowly getting better, but this guy lives with pain for years. Yes?
Do you block the otic ganglion?
Sometimes, either before and after surgery, yeah.
Repeat the question.
I was asked if I do otic ganglion blocks, phenopalatine blocks. I do a lot of stellate ganglion blocks. Those seem to help a lot. I do a lot of conscious sedation on patients who are in pain after my surgeries to try to get the thalamic pain memory pattern broken up. And then once I get them relaxed with a little Valium or something, then I do the nerve blocks, and they respond much better.
Chris,
Yes?
one thing I notice when I do the Stabident procedure, and you find out that there is a cavitation.
Let's do this.
This happened to me many, many times to diagnose a cavitation. When I do a regular Stabident block now, I get an autonomic response. That means it's a cavitation.
Okay, well, define what you mean by autonomic response.
Sweaty hands,
Okay.
faith, and that's almost me now. It's 100% they are cavitations.
That's a great
That's
point.
a big pro, because I've done that for so long, and it's a standard procedure now. That's what I do. When I do a Stabident procedure, when the patients have even cardiac pain, and they have autonomic responses, I'm for sure now that they have cavitations. That's probably one of my best, most conclusive tests.
That's a great point, because I really believe, and Dieter was on this years ago, knowing that the effect that these have on the autonomics. And the major complaints, chronic fatigue syndrome patients, so many of their complaints are autonomic. And if you go back in some of the old dental literature, which I have, dental medical literature, there were articles and stories written about this autonomic dystonia from these things. And I think that's a great point.
But the patient is very mad at you afterwards.
Yeah. That's, well, warn them, say, look at this, 99% of 100 patients, you're going to feel better after my block, but you might be one of the 1%, but tell them, hey, that's a positive sign. We found something, So don't do serial root canals. I don't do root canals anyway. First root canal I ever did in practice, it was a little old lady across the street from my office, getting ready to retire from General Motors. This is back in Lansing. I did a beautiful root canal on a canine tooth. It was beautiful. Gut approach. I was so proud of it. She was dead in a month. And I figured, in my mind back then, I'm going, geez, maybe I missed something, or what was that? And my partner said, oh, you're crazy. You're fanatical, And then I told him about mercury, 5 years later. He says, you're really nuts. And then he went on to promote the fluoridation of the Michigan water to the Michigan Dental Association, I saw my old partner a couple of years ago. I went to see him, and I hadn't seen him in years. And when I went back to medical school, he wouldn't talk to me. And he was still doing mercury fillings, and he looked so sick and ashen and gray. He looked like a mercury filling himself. All right, here's how you do the little neural therapy injections for those of you who don't know how to do this. You want to try to get your needle right about where the apex of the tooth is or used to be. No big deal. And you use little 30-gauge needles. You want to put a little topical on, that's fine. Okay? And use a 1/4 to 1/2 cc of local. You don't have to do that, actually. And when you're working on the front and you're not quite sure where the lesion is coming from, try to work from the front back, like from the number 8 or the centrals back to the posterior area. And that reverses on the lower. If you're not quite sure where the extent of your lesion is on the lower, you start from the third molar area and you swing your way forward and come around to the buccal mucosa. Now, on the lower, if you think you got some kind of response doing a long buccal injection or infiltration, and you're not quite sure, you got some response but you want to see, then I go to my long buccal, I go to the inferior alveolar nerve block and I block the whole jaw. If that takes care of the pain, then I know that confirms where it's coming from. And it also tells the patient you found something. If you injected something and your back pain goes away, and you have them come in the next day and you do the same thing again 2 or 3 times, they start to wake up. Those who aren't Democrats will wake up. Okay, in the lower, similar situation down here, okay? Always include in your testing vitality testing. And use, this is the best machine I've seen, the analytical technologies. It's a little mini computer, and you have a little dental probe you put on the tooth, and you have a little ground here. And it gives you a little readout. It goes from 0 to 80, and you have a little scale. Centrals are usually 10 to 30, and bis are from 30 to 50, and molars are usually from 50 to 70. Document that in your chart. Yes, the tooth tested, vital or devital. If it's devital, there's no question. Then they have a choice, either extraction or root canal, or leave it alone. If it's high vital, it's close to being dead. If you have a tooth that you touch and the patient goes through the ceiling, that's a hyperemic, chronically pulp-infected tooth, and that's the same thing. It's as good as being dead. But document that in your chart. You pulp tested the teeth. Document that you percussed the tooth. If you want to do cold and hot testing, that's okay too. Document it, because if you have to go up against a board or something like that, you've done your homework. Whoop. Story of my life. Okay, this is from Dr. McMahon's work and Dr. Ratner's work. 4 things that can happen if you do a nerve block. You can, if you have a lesion in the jaw here, the lesion, after you numb this up, can refer, you can start getting numbness in the upper jaw. You haven't blocked up here, but it sure feels like the patient says, how come I'm getting numb up here? You can numb them up, and you won't get any more anesthetic beyond the cavitation. You can get partial numbness to the lip, and that's what you see when you're doing a crown prep and you still get sensitivity. And you say, I can't understand it, you should be numb. Or you get full terminus, and this is what this is. You get full anesthesia from your injection. This is called full terminus, this is called bridging, this is called blocking, and this is called divergence. And basically, it's understanding the anatomy and the physiology of the trigeminal nerve. I haven't even started drinking yet. How do these look on X-ray? Poorly demarcated radiolucencies. There's moth-eaten radiolucencies. There's focal destruction of the canal. That is a key point. When you see that, there's no doubt that you have a cavitation. Lamina dura remnants. Jerry talked about this. Lamina rain. Socket sclerosis, also called Jacob's ladder or horizontal trabeculae. Then you see the little rat's nest, the radiopacities, the microcalcifications. This is the woman that had the cavitation that I cleaned out in this area here that treated her neuralgia in the left arm. Very simple, takes you an hour to do, and you're a hero. Nothing major, you're not going to destroy anything, there's no major nerves up there. It's so much easier compared to doing a lower lesion. She had a cavitation here too, see this one? And one here, look at, you see the outline right there. This is when I first started, this was back in 1988. Another cavitation. This is from slides from the ADA exam, sample exam. And of course, they wanted to show, I don't know, they were showing the arrow here. And they, of course, they missed the whole subject here, which was the cavitation. I thought that was kind of ironic. But, okay, here's a patient that has a cavitation under a bridge. You see the socket sclerosis. This was a friend of mine who had chronic back pain, T3, T4 back pain. Her husband was a chiropractor, and he would manipulate her, on a daily basis and could never get rid of her back pain. We did a little neurotherapy. We squirted her with a little lidocaine, and her back pain would go away for a day. We cleaned this out, didn't destroy the bridge, just made a little flap, cleaned out underneath it, and her back pain went away. Simple. when you open these up, what do they appear like? You get a minimal surface change, but the keynote is when you stick your little burr to make your access window, you'll get little chicken soup floating out on the blood. You get these little fatty globules that float out to the surface and down. That's your first diagnostic sign. Can you all see me? Sometimes, and I've only seen this on 1 or 2 occasions, the gritty sawdust that Jerry talks about here. You see bloody open tubercula, which I see all the time. Chocolate ice cream, I've seen this on 3 or 4 occasions. What looks like chocolate pudding you'll take out. And sometimes it looks like dirty motor oil because basically you have degenerated fat that's oxidized and it'll come out black or green. I've seen, usually when you open up a nice cavitation, if I can use that word, nice cavitation, you'll take you'll unroof your surgical window to get access inside, and you'll see white fat globules. And that's the first thing I do. I go in there with a manual curette, and I try to get as much of that fresh surface as I can, along with bony spicules and anything else that I can get out of there, and then put it in the biopsy container. You've seen this picture? The point I want to make here, without belaboring this, is this canal is a great medium for tunneling. These things love to tunnel. And you'll find when you start doing these, if you have a third molar cavitation and you have a second molar still present, that these things will travel underneath and they'll start destroying the tooth underneath or in front of it. You can have a vital tooth as a second molar and have dead teeth as a result of the cavitation coming forward, destroying the blood supply to the teeth in front from a tunnel. So when you're doing a cavitation in a third molar area, I have some really blunt, like endo probes that I try to insert to find out if there's anything else I need to do, if I need to follow that or track it. And I tell a patient, I say, look, this molar, the second molar is vital, but it may die as a result of the surgery. I'll try to be really conservative and not destroy the neurovascular bundle to the tooth, but that's a risk. Life is full of risks. Third molars. Do you see the destruction of the bone around that third molar? Do you see this? And the same thing here. This bone is necrotic around here, and there is always a dentigerous cyst or an odontogenic cyst. Jerry, what's the right term for a tooth that doesn't erupt? Is it odontogenic or dentigerous, the cyst that's associated with that? Dentigerous cyst. And you have to get the cyst out. You cannot leave the cyst behind because a cyst is a focus. It's usually infected, and it's a disturbance on the body's electrical system. So you're taking out the third molar, you clean out the bone, you get a bunch of soft, mushy material out. You make sure that you've gotten out that cyst, and usually you have to peel it off a side of the socket. Okay, I talked about the tunnel. The cavitations will tunnel. You have to look for that stuff. Dr. Reggiani in Michigan, who first introduced this to me 10 years ago, always told me about a case. I'll never forget this. It was sent to him with a patient with a lymphoma in the pelvis. And she had 3 or 4 root canals in the lower anterior mandible. And as you know, if you don't know, the body, the anterior regions, corresponds to the urogenital system or pelvis. And he started taking out the root canals, and he found that there was a tunnel from one canine to the other. And this patient survived. The tumor went away after his surgery. And is it the osteonecrosis? Is it caused by infection or is it caused by ischemia? It's probably caused by both. And it's also caused by trauma, and it's probably contributed to heavy metals and vasoconstrictors. Here's a graphic presentation of a cavitation. This infected tooth was removed. We got a socket here that never healed up. There's socket sclerosis. You have a lot of bradykinins and substance P released, and those are conducted via axonal transport back up the trigeminal nerve to the trigeminal ganglion. And from there, with the connections in the brain, it causes havoc elsewhere. We know they're not classic osteomyelitis because most of the time they're necrotic. We're beyond the osteomyelitic stage. We're beyond the infectious stage. The body can't heal beyond the infection stage and the bone dies. We find altered blood vessels. We find altered nerves. Jerry showed you slides of these earlier. We find some inflammatory cells, but usually not as many as you would expect for an inflammatory focus. And we see poor bone healing. We won't get into that. Here's a cavitation depicted in a third molar area. We have some fistulation or wormholes. We have an example of it coming forward around the tooth. We have destruction or demyelination of the inferior alveolar nerve because of the cavitation. And we have bone destruction. We have fibrin formation because it's a lot easier for the body to form fibrin in an anoxic or hypoxic environment, not enough oxygen. Dr. Schaub is here from Oregon. He has a clinic on his chronic fatigue patients. He takes venous blood samples. What's your record now for a chronic fatigue patient? You just told me, young woman.
11.4 in elderly lady.
Well, PO2 was what? Here's a woman walking around with a venous O2 of 11%, chronic fatigue. And what was her CO2, remember? Okay. These patients have low oxygen tensions. We all have low oxygen tensions. But these patients tend to be sicker than others. Most of the patients Dr. Schwab sends me have O2s consistent with somebody in congestive heart failure. These are, this is a depiction of what mandibular lesions can do as far as referral patterns for paresthesias. Remember the movie? The young lady who had third molar cavitations in upper and lower? She would be walking along and her legs would give out. These are stippled areas showing the pain pattern, the paresthesias, the neuralgias that you can get from lesions of the mandible. This is from Dr. Ratner's paper. These are symptom referral patterns pertaining to lesions of the maxilla. In other words, the upper jaw can cause chronic C1, C2 lesions. Pain down the entire spinal cord area, and pain that refers down to the arms. Usually the medial distribution, but that's not cast in stone. Medial nerve distribution. Groin pain. I have a movie, I don't think we'll have time to show it, of a woman who had gorgeous dental work, fixed crown and bridge work, 7 or 8 root canals in the maxilla. She came to me, she said, I've heard about you. If you don't do something, I'm going to die in a year because I have groin pain. I've had it for 20 years. I show real estate. I can't even walk anymore, and I know I'm dying. Can you please do something? I did neural therapy, injected all the upper teeth, and within an instant, her knee pain went away, her groin pain went away. All her symptoms went away within 5 minutes. I took out all her upper teeth, biopsied everything. It was all necrotic. She had a denture made. She made me a tape. She said, you saved my life. I can walk now. I'm showing real estate. And if I hadn't done anything, I would have died. Most beautiful dental work I'd ever seen. Her chronic groin pain went away. This is a man who got struck in the face years ago by a baseball bat. He had a fixed bridge here and a removable partial. When you pushed with your finger, it was tender here, and you basically, the bone was mushy to feel. Okay? He had paresthesias of both lower extremities, posterior aspect of the leg, like the slide I just showed you previous to that. This is his this is what it looks like close up. He had a root canal here, but this is all osteonecrosis. And this was his pain pattern. This is the calf area, the posterior region of his calf. And this was all black, cold. I injected his mouth, and his pain went away down here. He could walk. And he had had 25 milligrams. He'd been to the Mayo Clinic half a dozen times and every other neurologist in the area. And I said, your problem is from your mouth, and it's causing this problem. And he told me I was crazy, and then I'd never come back again. But it's kind of like the Fram Whale commercial. Now, you can pay me now or you can pay me later, you know. This is the odonton chart showing the relationships. I won't belabor this point. Third molars, our cardiac meridian, chronic fatigue, peripheral neuropathies. And this is the most frequent place I work. Urogenital problems are in the front of the mouth. Prostate cancer, I believe, is from third molar pathology, and this probably applies to ovarian carcinoma. The third molars correspond to the S1, S2 sacral plexus. Prostate disease is in part due to autonomic dysfunction. There's been several articles on it, and Dieter taught me this years ago. I've had patients who were obstructed with benign prostatic hypertrophy, and there was some malignancy in the gland itself. I muscle tested him. I injected the root canal that was in front of the mouth and third molar areas, and he was in the bathroom in minutes urinating. We took out the third molars that were impacted, took out a root canal. His PSA has gone down, and his tumor went from the size of your fist to a walnut size, normal size. And his urologist says, geez, what are you doing? And he said, oh, I'm just taking some vitamins. Same thing, different depiction. This is an important slide showing the anatomy and the importance of knowing neural therapy to do the audit ganglion, which is up here, the submandibular ganglion, to do the sphenopalatine injection, where you do it from the oral approach or from the external approach, or you just have them snort a little lidocaine. It's one of the easiest things you can do in the office. You have a patient say, well, let's see if this helps. So if they snort some lidocaine, they're going to touch the sphenopalatine ganglion, which is back here. And if their headache feels better, then there's a pretty good chance that you have some type of dysfunction of the sphenopalatine ganglion contributing to their facial pain or their headache. The point on the last slide is I'm going to show you all these are autonomic fibers. Here's a stellate ganglion down here. And they're all related. It's all the same wiring diagram. This is a neat depiction. This little group of nerve bodies here is all motor control to the muscles of mastication. That's it. The blue object here is the entire sensory ganglion to the trigeminal nerve. And it comes all the way down here, and it is probably 2 or 3 inches long, and it continues down the spine in the form of the substantia gelatinosa. So this is kind of like a large building with an elevator. And it depends where the elevator gets off as to where you're going to have remote pain disorders from these cavitations. Okay, motor, sensory. So that's why the cranial nerve number 5 is so important, because it gives you sensory, it gives you temperature, it gives you touch, it gives you sensation and pain back to the brain, and there's so much of it. It's more of a sense organ than it is motor. And this is just depicting it going down through the spinal cord. Substantia gelatinosa is this area of the spinal cord, posterior rami. Now, I'm going to show you just real briefly some articles in scientific journals showing the relationship between the trigeminal nerve and different organ systems of the brain. This one is extraocular muscle proprioception and the descending trigeminal nucleus. This was in experimental neurology back in, I think, 1976. I can't see it from this angle. So there have been scientific articles done on this stuff, showing the relationships. It's out there in the literature. Trigeminal primary afferent projections to the non-trigeminal areas of the rat central nervous system. Convergence of cutaneous, tooth pulp, visceral, neck, and muscle afferents onto proprioceptive and non-proprioceptive neurons in trigeminal subnucleus caudalis, and its implications in referred pain. Studies of the principal sensory and spinal trigeminal nuclei of the rat, projections to the superior colliculus, inferior olive, and cerebellum. Projections from the spinal trigeminal nucleus to the entire length of the spinal cord in rats. Okay, how do we treat these lesions? Well, antibiotics are okay. Oftentimes they'll buy you time. They'll give a patient, you can't see them for a couple weeks, you put them on antibiotics, it takes away some of their pain. You can use it as a diagnostic tool. Say, look, I think you got an infection in your jaw, and I think it might be causing your pain. Why don't we put you on some antibiotics, and let's see if it helps. Now, if there's still some osteomyelitis left or some infection, they will get some results. And if they have a lot of osteonecrosis, chances are they're not going to receive too much results or relief from the antibiotics. Do you follow that? And I usually use antibiotically, I use either Augmentin or Cipro. You can try penicillin, but most of the time the patient's bugs are resistant to penicillin. Sometimes doxycycline or tetracycline works well for these because it covers anaerobes. And I've seen more and more people be sensitive to tetracycline. Now, usually if you go to your neurologist and you have trigeminal neuralgia or facial pain, they're going to put you on Tegretol or gabapentin, or there's numerous new kinds of neuroleptic medications. This raises your seizure of threshold, but also raises the pain threshold. The patients are zombies. I'm sure you've all seen patients on Tegretol. It's not a treatment for this. It's not even a diagnostic tool. Neurosurgery, this in part refers to some of Dr. Giannetta's work, who was a neurosurgeon that patented the Giannetta procedure, which is a posterior decompression of the trigeminal nerve and the local artery around it. If you are those of you on the internet, you dial up trigeminal neuralgia and you'll download 20 or 30 pages of patient suffering. And many of those patients have had this surgical procedure where their brain's been opened and they still have problems. I had a call a couple weeks ago from a young guy who had his brain opened 3 times and now he has intractable pain. It's not from his brain, it's from his jaw. decortication of jaws. Yep, decortication and curettage. You have to do both. That usually will get you in the ballpark, and at 72%, you'll get a really good cure rate. The most common areas are the third molar areas, 45%. The next most common are first molars. They come into the mouth first. Obviously, that's what I call first molars. And they're usually infected first, or they have caries first, or they get root canals first. Jerry showed these slides earlier. Don't worry, the death rate from this wonder drug is only 5%. This is that gentleman's maxilla. Jerry had slides. He gave me this one. I always like this slide because it scares the living daylights out of people. So when somebody tells you Nicos don't exist, you can show them this slide. That should defer their thinking. Is that the end of that carousel? Yeah. Next one, please. I'm going to show you, we're going to get into the surgical aspect here and what I use and little tricks and stuff, and then we'll field some questions, and then I won't bore you anymore. Great spirits have always encountered violent opposition from mediocre minds. Albert Einstein. This is just a real basic surgical tray. This picture is a couple years old. I use a Minnesota retractor that I've had made up special with a little wider blade, because when you start doing the edentulous jaws, you're going to have to retract a flap that's maybe 3, 4, 5 centimeters long. And this instrument would be too short for that. And of course, I don't use vasoconstrictors anymore, which would be in this carpool here. Since I do a lot of IV sedation, I always monitor the patient with a little pulse oximetry. This is a little device. A little clamp goes on the patient's finger. There's a photo cell in there, and it'll tell me the patient's pulse, and it'll tell me the percentage of oxygenation. And there's a little beeper, so that I don't have to look at that all the time. I can be working. If I hear something, then I can look and see if the patient's having a problem. It covers you, and I feel better. I feel more safer with this when I'm using IV sedation. Now, this is some of Bill Wolf's stuff, aloe vera gel, and sometimes I put this inside the surgical site. You might want to think about putting this after you've done your cavitations. If you're just doing a simple extraction, you've cavitated it, you've cleaned it out, you want to put some aloe vera into the socket site and have the patient bite on it. This will promote healing. It's antiviral, antifungal, and antiparasite, and antibacterial. Another thing I want to show you down here, this little brown bottle, is called nandrolone decanoate, also known as decadurabolin. And for those of you older physicians or dentists who probably are aware of this, this is an anabolic steroid. American medicine has taught us to be very afraid of anabolic steroids. Well, if you look at some of the new literature, and it's on the internet, anabolic steroids, for some reason, seems to help AIDS patients. It increases CD4, CD8 counts. The old physicians that I trained under used to use nandrolone for cancer patients back 30 years ago who were cachectic, and they all got better. Their appetites increased. They felt better. Your patients will be catabolic. They'll be cachectic. You need to augment them with this steroid. This is a very safe steroid to use, nandrolone. You can buy it generically. Shine has it. It's about $5, $6, $7 a bottle. It helps to release growth hormone. It stimulates your immune system. It promotes building of muscle mass, and you don't even have to work out. Injectable form does not play with the liver at all. You don't have to worry about the liver, even in patients with hepatitis. Usually, I don't have the luxury of seeing a patient. They come into town, I do surgery, and they leave. So I usually give them like a 200 milligram shot a day before surgery. Or I'll give them a couple vials to take home with them. And these patients that are wasting away, you give them usually 100 milligrams every 10 days. Have them take a shot. And I'll come back in a month or two later for more surgery, and I say, how you doing? I go, I'm feeling great. My appetite is ravenous. And they eat, and they feel better, and they have more immune system. They have protein intake. Well, it's known as decadurabolin, D-E-C-A, durabolin, D-U-R-A-B-O-L-I-N. That's the trade name. That's more expensive. But you can get it generically as nandrolone, N-A-N-D-R-O, or N-A-N-D-R-A-N-O-N-E, decanoate, D-E-C-A-N-O-A-T-E. Get it from Shine. Stock up on it. when you're dragging your fanny at the end of the week and things like that. I am, right.
How much? How much you give?
If it's a surgical patient, if you can get the luxury of, ideally, it'd be nice to do this a couple weeks before surgery. Give them 100 milligrams every 7 to 10 days. Tune them up, because then they'll heal up so much faster.
Is that synthetic?
This, I believe, is.
What is the relative of where's it coming from?
I don't know. I don't know. But it muscle tests very well. No, it's not testosterone. Speaking of that, I do use this in combination with testosterone, even on females. I use a little testosterone, and I use a lot of this. This is non-virilizing. So you don't have to tell your female patients they're going to grow beards or anything, okay? They won't. They might grow a testicle or two, but they won't grow a beard. Seriously, no virilizing with this. It's the best, it's the cheapest, it's the safest, it's the most anabolic with the less virilizing capabilities.
What's the dose after surgery? 100 milligrams how often?
Every 7 to 10 days.
No side effects, no bad side effects.
Haven't seen it yet.
Chris, what if you want the virilizing side of it?
Use more testosterone. Use more testosterone. Pardon me?
What's the half-life of that steroid?
In vivo?
Yeah.
Don't know. The longer the better. It's not cortisone now. Okay? All the latest literature is it augments immunity. They're doing study after study after study on it. There's a DO in Texas, in Houston, Texas, Arlette Farrell, that's doing tremendous research with this. And she has all kinds of cancer patients and AIDS patients. See, these are some of the medications I use. IV. I use Versed or Valium. That's diazepam. Valium is very cheap. It's easy to reverse. The only problem with Valium, it has a longer half-life. Patients are a little groggier. Versed is a lot more expensive. You can use less dose, so there's a critical thing there. You have to be careful how much you use. But the half-life is a lot shorter. So I muscle test my patients. I have a little basket, and I have all these medications in there. I see which ones are the best. And I do the same thing with antibiotics, okay? This is Demerol. They throw up on Demerol. I rarely use this anymore. Everyone throws up on Demerol. They swallow a little bit of blood. They swallow a little betadine and all that stuff. Then you give them some Demerol, and they always throw up. Brevitol is for somebody that you need to work quickly and rapidly, knock them down, and have them recover quickly. I don't use this very often. You have to mix it up the day you use it that day, and that's it. For those of you that don't have an MD they work with or don't know conscious sedation techniques, you can give them Valium IV tablets. Give them some tablets so they sleep the night before, and have them come and take 1 or 2 tablets in the morning so they have a little bit of a buzz on, and they feel much better, and your surgery will be much easier. The more uptight these patients are, the more you're going to incite the sympathetic nervous system. They're going to get autonomic reactions, then their blood supply is going to shut down. Then they don't heal up. And for 3 or 4 years, I did surgery with just local anesthetics, and I don't know how I ever did it. Aquamaphyton, if somebody's come in and they've been on heavy-duty aspirin or nonsteroidals and you think they're going to bleed excessively, give them a shot of aquamaphyton. This is vitamin K. Always think about your flap design before you make your incision. Always make the base of your flap wider than the apex. You got to make sure that you preserve your flap integrity. You want good flow to the flap. So you always make your flap wider at the base than you do at the apex, okay? And this is the type of flap I use for third molar surgery, usually like this, or a modified form of that. So you plan your design before you do the surgery. For example, if you're doing a lower cavitation, and you're going to take out a tooth, and in addition to that, where the tooth was, you're going to have a hole. You got to close that hole. So you're going to have to move that tissue around, and you either have to undermine it, you hold it up with a tissue forceps, and you take a blade, a scalpel blade, and you thin the periosteum, then you take a blunt dissection scissors and open that up so that you can move tissue. You got to close that hole because it's going to reinfect. So I do plastic closure all the time. This would be an example of an anterior flap, lower anterior, trapezoidal-like, wider at the base than the top. And usually I go over at least 1/2 to 1 tooth over. This would be an example of a cavitation with removal of 2D vital teeth with periapical granulomas. You make a wide base, more narrow at the top, come forward a half to one tooth, flap it back. If you're going to remove in crowns or you're going to section the teeth, section the tooth before you lay your flap, because you don't want all that gold or grindings or tooth particles to get into your cavitation and infect that. So try to think ahead of what you're doing. Try to be as aseptic as you can. Take your crowns off first. Do all the dirty work first before you open up into the mandible.
Get all the amalgam out.
If you have that luxury. I don't do that anymore. I'm not a dentist. You are. I think that would be great. And I've told you this before. The granddaddies of this, Radner and Roberts, never had that luxury. They never looked at that. And they had patients who had facial pain, and they cured 80 to 90% of their patients without removing the mercury. Okay? The first patient that I saw, I showed you the filament, I didn't remove the mercury. If you have the option, great. I'm not a fan of mercury, believe me, I hate it. This is usually what I use for third molar flaps, a little envelope type flap. And I come forward, I extend this a little bit more forward this way, the vertical incision. If you're working on a third molar, upper third molar, you can either come one tooth forward. I tend to be more conservative, and George has told me about this. He likes to be more radical, but I just use one little incision like this, keeping the base wider than the apex. This is what you do under a bridge, for example. Same thing, envelope type, under the bridge. Don't disturb the teeth on either side. You will find where you go into these areas where a root canal used to be that you'll have oftentimes a cavitation that wraps around the nerve in that point. And you have to clean that out. Here's some pictures of doing cavitation work. This was years ago when I first started doing this. This is a woman, chronic fatigue. Everybody wrote her off as a hysterical female. And every time I would inject her, her facial pain would get better. And she had had bite splints and orthodontic therapy. This is a flap. This is the bone underneath. This is the hole. I make a little window first with a 557 surgical burr with irrigation. You've got to keep your bone moist and cool. Don't fry the bone. It's fried already. Don't make it any more necrotic than what it is. Don't insult the autonomics anymore because they're going to shut down more. I open it up so I can see. I go in. Whatever window I take out goes right into the biopsy bottle, and I send it to Dr. Bucko right away. I take a big curette, and I go in and try to get as much as I can out, manual curettage. All that goes in. And then if I'm digging some more and I find more stuff that I think is going to be really interesting, or I want to bug him by staying up all night and have him do all my dirty work, then I send him more stuff. Okay, now, I was trained allopathically, osteopathetically, whatever you want to call it. You have infected bone here. You are theoretically, of course, out on a limb by doing this kind of work because these things don't exist, as you know, all right? So why don't we just sterilize? Let's put a little antibiotic in there, okay? And the reason you do this is because the people who did this before you did that also, and they got good results. So I take a little vancomycin, a little gentamicin, and a little clindamycin that I buy from Shine. It's real cheap. And I mix it together, maybe a half a cc of each one or a cc of each one. I dilute it with a little bit of lidocaine, a little bit of DMSO, and a little bit of water, bacteriostatic water. And I use that for my irrigation. When I'm sure, or when I think I've got as much as I want to get out of this cavitation, I put a little 2x2 dressing into the wound site, and I have this made up in a syringe, and I inject into the 2x2, and I saturate the 2x2 and leave that there for 5 minutes. You can leave it there for 7, 10. You can go out to the local bar and get a drink and come back. I don't care. Sterilize it. You're working in the dirtiest area of the body.
What is this third one that you are using?
Clindamycin. And that's primarily for the Gentin and Clind are mostly for anaerobes. The Vanc is for the resistant organism that you find in there. Okay, I use Marcaine, 0.5%. I buy it in multi-dose vials, and I usually use a little lidocaine with it, preservative-free, and I use Procaine, 2%. I usually get this preservative-free now. This is an old slide. This is preservative-free, and there is no vasoconstrictor in this. No vasoconstrictor. The Marcaine gives you long-lasting anesthesia. It's cheap. It works good. I've never had an allergic reaction to it. You just want to make sure you're not in a vessel, so you always aspirate first. And I'm sure I've gotten into a vessel. I never had a problem, but that was right inside the jawbone. Marcaine, 0.5%. And I think you consider using this also for general dentistry. If you're doing long procedures, crown and bridge preps or bridge preps, you can get 0.25% also, which might be easier for crown and bridge or general dentistry. But please don't use a vasoconstrictor. I have this zinc bottle here, and I'll tell you what I was experimenting with. You remember Dr. Huggins was using protamine zinc insulin after surgery. He was putting a little squirt in there, and your patients would heal up dramatically. Well, you can't get protamine zinc insulin anymore as far as I know. So I thought, well, what does zinc do? Zinc heals wounds. So I used to mix a little bit of zinc, a couple drops, and this is really cheap, with a bunch of lidocaine and a little DMSO, and flood my site, and then put it into the gum afterward. And oftentimes these patients would heal a little better because they're so depleted anyway. Most of these patients have the peak cube syndrome. That means piss poor protoplasm. And you can't do enough for them to stimulate their healing. So this was one tool I was using. However, through my muscle testing, the body says, wait a second, you got a patient here who's pretty sick, and there's some mercury in the jawbone and probably some other metals, and you don't want to mix the two, zinc and mercury. So what I've been doing now is, as a last rinse or last final step prior to closure, is I take a 2x2 pledget, and I either saturate that with a little DMPS and maybe a little bit of EDTA, dilute it with some lidocaine and a little DMSO, and let it sit in there for 5 minutes. I'm taking out whatever heavy metals may be there, which is probably mercury. The EDTA will clean up some of the calcium that needs to be freshened up, and I'm kind of etching that. It'll open up the circulation. I take that out, and I just sew it up. And my patients have been healing better. When I'm ready to do final irrigation, I take some peroxide, and I take some betadine, and I dilute it, and I first sterilize the cavitation with betadine, peroxide first. I don't know if it makes any difference in betadine. I dilute the betadine usually 3 to 4 to 1, 3 or 4 waters to 1 part betadine. The reason I use that is because it's antiseptic, it's bactericidal, it's virucidal, and it's fungicidal. And it's the only thing I really use that can kill viruses when I'm working in there locally. Now, what else can you do? I developed this little trick. When you're working and you kiss a little vessel and you get a little bleeding, and you go, oh my God, I got a hemorrhage, don't reach for your vasoconstrictor. Buy some vitamin C, liquid IV, or liquid vitamin C that you would put into an IV. Draw some up, mix it with a little lidocaine or procaine, put it on a 2x2 gauze, and put it over the area. Vitamin C is a sclerosant, and you'll stop the bleeding. The vitamin C will also kill viruses, and it's non-toxic. And you want to buy the vitamin C bottles that are preservative-free.
Where do you get liquid vitamin C?
Apothecary. What do you use in your IVs? Your vitamin C IVs. Same stuff. Merit, McGuff. When I had more time, I used to play with ozone. And I got this from all the German textbooks of dentistry and medicine. I bought this old ozone chamber from a pool supply company. There's an arc light in it. And I used to hook up my oxygen tank on one side, and I would blow pure oxygen through an ozone chamber, and I would go from pure O2 to pure O3. And I would bubble this into some normal saline or clean or sterile distilled water, and I would use it for irrigation. That took a lot of time, and there isn't any time anymore, so I just use sterile saline, and all the dental companies have these irrigation bottles now. I just fill that up, and I have a syringe, air water syringe, and I use it to irrigate. Ideally, it'd be nice to put ozone in there because the bone heals fast, and that kills everything too. Right, Dr. Rissels? Ozone? This is something you can use if you got a real good bleeder. I had never used this. I got this from Dr. Allender. It was just one of his tips that he passed on. I use this once in a while. These are little collagen wound dressings. They make a ribbon, and they make a little plug here. If you're working on the maxilla and you perforate the maxillary sinus, which you will, don't worry about it. If you're in there, you take a look, put your suction up there. You'll suck mucoceles out. You'll suck up inspissated mucus. I've had 2 patients this last week, young females with, their breath was so bad that it would knock a buzzard off a honey wagon detail, okay? And once I got all the mouth cleaned out, I went up, there was a little perforation in the sinus, and I sucked out this inspissated mucus that just was horrible smelling. Cleaned it all out, sterilized. I swished antibiotics right up into the sinus. I put my little patch on. I sewed it up, told the patient, don't sneeze, blow your nose, or use a straw for a week. Put her on antibiotics, put her on a decongestant, And the next day, they didn't have the breath anymore. And their husband said, "What'd you do? My wife, she smells like my wife again." I use the plug if it's small, or use the plug. Let's say you've done a cavitation, you took a tooth out, and you can't close it completely. Stick the plug in there, because it'll become saturated with blood, and it'll give you a nice nidus for a nice clot, and in a couple of days, you'll never even know where you were. The ribbon I use more for perforations of the sinus, okay? But experiment. You want to try different things. This is Calcitex. Calcitech, and if you call them, there's an 800 number. They'll send you a free package worth about $200 for this stuff. And then, of course, sometimes I use gel foam if you're used to using gel foam for perforations.
Do you have a phone number for them?
It's 1-800, call Calcitech. We'll call the 800 information. I don't have the number. I'm not that advanced. But call them. And Dr. Michael here was telling me that he does this kind of stuff, or gel foam, and he impregnates it with Notakil, and he'll stick it back into the cavitation site and sew it up. Nice idea.
What is it?
Notakil is a Sonum remedy. Or you can put antibiotics on it, saturate and sew it up. I use usually 3/0 silk. I was thinking this morning, wouldn't it be nice to get a little impregnated silk with silver ion, sew it up, and put a little current on either, a frequency generator from the outside. How much faster would that sew without any infection? Or how much faster would that heal without infection? I've experimented with Dexon or Vicryl. You don't have to remove the sutures, they'll dissolve. Or if a patient's going someplace and they can't get to a dentist for 7 or 8 weeks, I still like silk because it's the easiest for me to sew. Silk, though, the problem with silk, it acts like a wick, and it can bring bacteria into your wound site. The Dexon and Vicryl don't do that. And I have my patients irrigate their mouth post-operatively, starting a day or two later, 7-8 times a day now with warm salt water rinses. And they heal up much faster. I tell them, you can't irrigate enough. Gentle rinsing with a level teaspoon of salt and an 8 or 10 ounce glass of warm water, they irrigate their mouth.
Chris?
Yes?
You ever muscle test to silk?
I do. I have it in test kit, and some people are allergic to it. You're right.
I get a lot of people that are allergic to it.
You're right. I don't do it as much as I should, but I do once in a while. I'm suspicious, especially somebody who is chemically sensitive, a hypersensitivity, they will be allergic to silk. I have like different baskets. I have a little basket for suture, for antibiotics, for decongestants, for local anesthetic, and for IV sedation. And I usually try to check them as much as I can. I do other things too for check and run when I need to do it quickly, but yeah, you're right. And that's a good point. There are a lot of silk allergies, and you'll have some patients who you'll sew up and the sutures will blow wide open, and I think those patients are allergic to silk.
Yeah, me too. That's how I discovered it.
Yep. Same here. Good point. Thank you. Always, if you have the opportunity, if you do EAV or kinesiology or whatever you use, always check what you use, because you can, I've used DMSO for years and never had a problem, but a friend of mine was telling me this weekend, Gary Gordon, who was a DO down in Arizona, he saw somebody going to status epilepticus with a simple DMSO shot. So test everything if you can, and you won't have reactions. Make yourself up a little test tray with antibiotics. Put a bunch of capsules in clear glass test tubes and use those for testers. Whatever you use, put them in little test tubes, clear glass test tubes, and use those for testers. And you can use it through EAV or kinesiology. This is DMPS. When I use this, I believe that one of the major reasons we get cavitations, and this was known 200 years ago, that mercury causes maxillary necrosis, caries of the maxilla, if you will. And you've got to get the mercury out of there, or else they're not going to heal up. And it takes years to get the mercury out. So what I do after surgery is I take a syringe with some Marcaine. I want to give my patients a lot of post-operative pain relief. So I put more Marcaine when I'm done. I put a little squirt of DMPS. You can use 1 or 2 drops. And I put that over the surgical site. And I've been doing this on patients who come in a day or two later, and they're still having some pain, or they were good for a day or two, and now the pain's coming back a little bit. You muscle test them, mercury will show up. It's the toxic ganglion thing that Dieter talks about. Put a little Marcaine or lidocaine or Procaine, whatever they muscle test for, a little DMPS over the site, and the pain will go away. And usually it'll be gone. You might have to do that a couple days in a row. After surgery, I feed my patients. I give them this free amine, either 8.5% or 10% amino acid solution. They're empty stomach because I'm giving them IV sedation. They're usually cachexic. They don't eat very well. If they do, they don't absorb their protein. So I give them pure amino acids. I give them a little dextrose to raise their blood sugar. You can put antibiotics in here. You can put whatever you want in here. And they heal much faster. And I put 20 to 30 grams of vitamin C in addition to the amino acids right in the bottle. There's the same slide that showed you earlier, different viewpoint. This is the greasy material that comes out. This is the third molar area. And you sew it up. You sew it up very well. You do a plastic closure. This was a gentleman that I saw when I was still in Michigan, early retiree, about 64, 65 years old, worked for General Motors. And he was retiring. And he started having severe abdominal pain and multi-organ system dysfunction, and basically he was going down the tubes very fast. He had a root canal in the right maxilla, which was on the pancreas meridian. And his family dentist wanted to redo the root canal. I've been there about 30 years. And it was a little mobile, and there was a little radiolucency around it. And I said, well, I'll tell you what, it's going, and you're not going to have it redone. And because every time I would inject this tooth, his abdominal pain would go away, doing neural therapy. To make a long story short, I pulled a tooth out. When it fell into a cavitation as big as the end of your forefinger, he had pancreatic carcinoma. He died. And I've had 4 or 5 patients with pancreatic carcinoma, all had focal disease on the pancreatic meridian, all died except one young lady. And she was still young, and it wasn't that chronic. They all looked fantastic for a couple days after the surgery. I mean, like they just came bouncing in, but it was too late. Sorry about the quality of the slide. This is a young lady came in from San Francisco, trigeminal neuralgia. Look at that mercury tattoo. Your sickest patients will be those patients with cavitus. Cavitus. That's a new term. Cavitu. It's these damn dentures. Will be those patients that have cavitations and mercury tattoos. I guarantee it. And when you start digging these things out, you got to try to get as much of the tattoo out as you can. Always biopsy a tattoo because it might be melanoma, but you try to get as much as you can out without destroying the tissue. What you can't get out, you mix up a little DMPS, a little DMSO, a little lidocaine, and squirt right into the tattoo, and the DMPS will make the tattoo go away eventually. I never finished this lady. I just did her maxilla. Gave her 85% relief from her trigeminal neuralgia. And that's what it looks like inside. And I guess I've been accused of being a little radical and not very conservative. But when you've been on the other side of this and you've had 15 surgeries on your jaw and you've had a 9mm out one night because you didn't want to live anymore, you pretty much know what works and what doesn't work. And you got to get all dead bone. Because these things, the body doesn't heal up. It's not like you can leave stuff behind and say, well, let's let the body heal up. There's no circulation. They don't have the body just doesn't have the immune system to heal these up. So you can't be too conservative. You can be too conservative. Get all the dead disease bone out. Make sure that you're down to hard bleeding bone. If it's white and it's not bleeding, it's not right. It's ischemic. It's sclerotic bone, and you have to dig that out. It's as hard as pearl. It's like boilerplate. And you have to ream that out until the bone bleeds, or else it won't heal up. And those will be your worst patients, too. And Weston Price knew this years ago, that they have altered calcium phosphorus problems. I clean the bone till I see it bleeding. Once it's bleeding, I know it's healthy. If it won't bleed, I'm going to destroy the jaw. I don't do that, of course. And I rely on hyperbaric oxygen, and I'll talk about that in a minute, and other tricks, too. But you try to get down a healthy bleeding bone. That's going to be your guide. And this is sewn up. I couldn't get all the tattoo out, but you see I got a lot of it out because I would have big perforations in here. And you can see all the nice fine suturing that I do to try to close this completely. Heal by primary intention.
What's the proportion of DMSO, DMPS, EDTA, and anesthetic?
Oh, half a cc of each one. Not very much.
So equal amounts.
Yeah. And I always muscle test first because somebody might be a little different, you know. This was what her hands looked like. And she had this almost like a psoriatic condition that couldn't be cleared up. I bubbled some ozone into some olive oil, and I had her apply that, which helped her considerably. But this went away after we cleaned out the mercury and the cavitations. This was a young physician back in Michigan that wanted to come work with me. He wanted to learn alternative medicine. And I don't like that word because I don't think I do alternative medicine. I do whatever it takes for the patient. You know, I get out my rosary beads once in a while because that's part of it too. But, you know, taking out infections in people's jaws isn't alternative medicine. That's normal medicine. And taking out mercury, that's not alternative medicine. That's common sense medicine. But anyway, this guy he was about 35, nice fellow. He had 2 young kids, and he had these 2 root canals. I didn't know that before, but he started having some back pain. He was in an HMO, and he just about had enough of family medicine. And he said he was having back pain, and he was seeing a chiropractor. And somebody had enough brains to send him for an X-ray of his back, and he ended up having an osteosarcoma of the left iliac crest. And I sent him to Vince Speckhart, who was a genius, an MD oncologist in Virginia that does EAV testing. And he said, he said, your cancer is from your root canals. And before I sent him, I took the root canals out. And he had 2 apicoectomies. Now, you can't see it on here, but when I flapped the gum back, his gingival tattoo was as large as a $50. I cleaned that all out. His bone was all dead and gray. He came in the next morning, and he was always kind of white and pale, but he had color. His face was red and rosy. He died. Sad story from root canals. This is just some mush. I always kind of measure it because on Dr. Boku's biopsy report, it always says how big is the lesion, so I always try to measure it. This is a woman who had uncontrolled blood pressure problems, and she had an impacted 3rd molar that every time I did neurotherapy on the 3rd molar, her blood pressure would stabilize and become normal. I took out the 3rd molar, and it cured the problem. The thing I want to show you here, this is a magnetherm. This is a pulsed magnetic machine that gives out alternating pulsed magnetic fields, positive, negative, and it can go from 500 to 5,000 cycles per second. And I always use this after surgery because it makes the bone heal faster. It increases the flushing out of lactic acid and increases ATPase activity. It makes my patients heal faster. I've been using little magnets. These magnets are like about a centimeter in diameter. They're 3,800 Gauss. I label them and I give them to the patients. Green side down. Green side down. I use them. They can't have the magnetherm. They can't take that home with them. So I have them wear this for a week after surgery. They sleep with at least 8 hours a day. Green side down. This increases blood flow. It sets up a piezoelectric field. And it gets into more of what Dr. Flick was talking about this morning as far as augmenting the body's electrical systems to heal. Surgically preparing them with nutritional aids, some type of bone complex, calcium, magnesium, boron. I use some homeopathic medicine. I make my own osteomyelitis nosodes, which I have the patient take before they come, and they finish that up after the surgery. You need to do things to promote circulation. You can have them take aspirin if they want. Some guys I know do this procedure, have a patient taking aspirin because they're going to be a little more, they'll have less tendency to clot, but they can tell better where the bone is healthy and where it's dead. So when you're doing your surgery, you can get a better idea of what bone is bleeding and what isn't. I don't like to do that because you tend to get more hematomas. So I tell my patients no aspirin compounds for a week before they come, or no nonsteroidals. And sometimes the patient doesn't know what an aspirin compound is. You got to tell them, don't take aspirins or nonsteroidals before you come in. If you feel kind of gutsy and you want some help, then say, well, take an aspirin, we'll see where your blood is, your bone is good and where it isn't. I use a lot of L-arginine, which is a vasodilator. It promotes the formation of nitric acid, which is a vasodilator. I use a lot of garlic. I use a lot of homeopathic remedies for vasodilation. I use a lot of vitamin C, calcium, magnesium, boron. I repeated all those things. Vitamin E is a very good antiplatelet aggregator in fish oils. And you can experiment with all those things. B12 folic acid, they need all that because if they have elevated homocystinuria or homocysteine, they will be, their blood will be much thicker. Some of the things I use, bromelain is very good, also as a prevent platelet aggregation. They don't swell up when they're on bromelain as much. I oftentimes will use heparin in their IVs a day or two later if they muscle test for it. This is a coagulation disorder of hypercoagulability. Sometimes I put them on Coumadin. Sometimes I use Winstrol, which is an anabolic steroid, and it's not for the anabolic nature of the chemical. It's because Winstrol interferes with factor number 5, Leyden factor, and they don't clot as readily. L-arginine for difficult cases. Now, how else can we increase blood flow to the head? Hang upside down. I bought this little thing for my back, but sometimes I have patients, if they're in trouble or they're home and they say, what can I do? I say, hang your head over the bed. You'll increase blood flow to your area. Now, this is the next tool I've gotten into. This is a Seacrest hyperbaric chamber. We are treating osteomyelitis, osteonecrosis, primarily from an ischemic viewpoint. We have no oxygen. We have hypoxemia or anoxia. We need to increase blood flow to these areas. Why do we use hyperbaric oxygen? We use it for osteomyelitis, we use it for chronic osteomyelitis, or we use it for refractory osteomyelitis, which a lot of us see when we do these cavitations. Those cases that fail to respond to healing in spite of surgery and antibiotics. Well, I try to beat this system. I put them in the chamber first. I put them on oral antibiotics and or IV antibiotics, and then I do surgery. The day after the surgery, I put them back in the chamber and I repeat that procedure. I just start doing it, and I'm getting some much better results. Okay, this is interesting. This is out of the textbook of hyperbaric medicine by K.K. Khan, who was a neurosurgeon from Europe. Osteomyelitis of the mandible is primarily due to untreated or unrecognized, kind of interesting, odontogenic infections, post-extraction complications, or fractures. Now here's a physician telling us this, our own business. Vascularity, more blood flow in the maxilla versus the mandible. The mandible is an end arterial supply. Don't use vasoconstrictors. Therefore, the mandible is more susceptible to infections. And Dr. Haley is going to talk about what we're finding inside these cavitations and root canals as far as infections tomorrow. What organisms do we see? Well, we touched on this earlier, staph, strep, and these are usually resistant. That's why I use the vancomycin, Chris. Eikenella corrodens causes sclerosing osteomyelitis. B. frag, actinomycosis israeli. Refractory osteomyelitis of the mandible or maxilla when surgery or antibiotics have failed. I like to use it at the same time. How does HBO work? Hyperbaric oxygen therapy can raise the tissue oxygen tension levels in partially ischemic hypoxic tissues. HBOT enhances the leukocyte-killing mechanisms that are oxygen-dependent via peroxide and superoxide production. HBOT by itself has been shown to be as effective as cephalosporins in controlling staph, osteomyelitis in animal models. Optimal wound pH can enhance osteogenesis or neovascularization to fill a dead space within vascular or structurally sound bony tissue. Improved vascularity facilitates entry of leukocytes, antibodies, and antibiotics to the infection focus. HBOT enhances osteoclastic activity to remove bony debris, and it stimulates host factors other than the direct effect on microorganisms. This we don't know much about yet. This is an example of how to do sphenopalatine with either, you can saturate these with cocaine or some type of viscous lidocaine, or you can have the patient snort lidocaine. Just some examples, some nerve blocks, supplemental nerve blocks, stellate ganglion, sphenopalatine ganglion, stellate ganglion blocks. Very useful injection post-operatively. Not all facial pain comes from the teeth. You got to know your trigger points. Dr. Klinghardt is a master in doing trigger points of this area, getting rid of facial pain or head and neck pain. So remember that. Car accidents, whiplash injuries, you have a lot of ligamental damage, fascial damage, and you have to address that. So you don't jump into cavitations all the time right away. More of the same. This is a woman with Raynaud's disease. This was back in like 1990 or 91. She had Raynaud's disease, 55-year-old school teacher. Early fall day, she had to wear gloves. Her hands got so red, white, and blue. She came in, and her hands were very dusky, and I injected. I tried to do everything. I was doing nerve blocks on her cervical spine. I was doing chelation. I was doing fish oils. I sent her to the University of Michigan Derm Clinic, and they couldn't do anything for her. We put her on Procardia, and nothing worked until I did neural therapy on the third molars, which were impacted. She was 55 years old. See the 4 third molars? And you can see the little dark areas around them. And her hands changed within 15 seconds. And they became warm, and they became normal color. I took out all 4 third molars. She was 90% better. There was one area, I think it was the lower right side, that became a little purulent. I went back in, freshened it up, sterilized it, sewed it up, 100% cure. She wrote me a letter, a testimony to the fact. Raynaud's disease, peripheral autonomics. There's a picture before. Now, a pearl, please, if you're going to take anything out of the mouth, please biopsy it. This is Dr. Boco's. You get a jar like this that's already pre-mailed, and inside is what you put your biopsy specimen. There's formalin in here. Biopsy, cover your rear end. If you're doing a little amalgam tattoo, put that in there. If you're doing a cavitation, put all your fragments in there. What if you can open up into lymphomas? You see primary bone lymphomas. I've had 2 in 8 years. So you do see cancer from this. But biopsy what you take out and tell the patient you're going to biopsy it and the reason you're going to biopsy it. And if the insurance company wants to know why you're charging for osteomyelitis, you go, well, here's the biopsy report. That's what I did. Now, I've just started experimenting. This is called a tissue crusher. It looks like a syringe. And then the end of this is a very hard, porous grinder. You take some of the bone out, put it in this, and put that in and kind of grind it together, and it kind of pulverizes the material. Then I suck that out with a syringe, and I put it into some aerobic and anaerobic cultures, and I send it to the lab. Done it a couple times in Reno. We don't have lab techs smart enough in Reno to look at it. There's a company in Oakland, a hospital, that's doing this special for me. They do find lesions in these things. So if you really want to get crazy with your culture techniques, this is how you do it. I don't culture too much because I pretty much know what's in there. And so I basically blast it with everything I can to kill the organisms. But if you want documentation, this is the best way you're going to be able to do it right here. Now, you have patients that have reflex sympathetic dystrophy. They have autonomic dysfunction of the face from trauma. You did too many dental procedures. They get hit in the mouth with a baseball bat. They get hit in the head with a golf ball, whatever. They have an RSD. You've done your cavitations, and every time you do a nerve block, the pain goes away, but it comes back. You have necrotic bone. You have an autonomic system that's not functioning well. I just started using this because I saw this ad in the medical journal. This is yohimbine. Now, you probably all know that this is supposed to stimulate blood flow to the pelvic organs, especially in a male. But it said it's a sympatholytic, which means it knocks down parasympathetic outflow, and it's a parasympathetic mimetic. So I've been putting some of my patients on who have RSD of the face, and they'll feel better in a day or 2. Now, this is Yocon. You can actually write a prescription for this. It's in the PDR that says use 5 milligrams 3 times a day. But if you go to a health food store, which is much easier, and your patients can get this, usually the tablets have 500 to 1,000 milligrams, and I have them take a couple tablets a day and experiment. And you can make a tincture. You can buy the powder and mix it with a little alcohol. You can put it through a little percolator like you're making tea and put drops on their area of bone where they're having pain, and you'll give them relief. So it increases blood flow to the pelvic organ, especially the genitals of both male and females. It's a sympatholytic, and of course it stimulates the parasympathetics. You want to use it for RSD of the head or atypical facial pain. You can use it as a diagnostic tool. It acts as an MAO inhibitor, so you want your patients to avoid tyramine amino acids, cheeses, alcohol, or chocolate, beer, aged meats, etc. And you can find it in this form, Yocon in prescription or at a health food store. Try it, see how it works. Now, there are side effects. I'm serious about the Yocon. Use that, all right? Now, my wife is related to Max Planck, and the Germans in here know who Max Planck is. And this quote I'll never forget, and I use it in all my lectures towards the end here. New scientific truth does not triumph by convincing the opponents and making them see the light, but rather because the opponents eventually die, and a new generation grows up that is familiar with it.
Amen.
That's it. Okay, the lights, please. Now, I know there's some questions, and I want to get Don up here. He's got to show us some stuff on laser. So let's ask a couple questions, and you can get me later at the wine and cheese party, if I'm still sober.
Condensing osteitis.
Yes.
What do you do with it?
You got to get it all out, or a patient's still going to have pain because that's ischemic bone, and you're going to have bone pain because the body's saying, "Hey, I'm crying out because I don't get any blood flow." So you got to put them on something that'll kill Eikenella corrodens, number one. Eikenella corrodens is a bug that's associated with sclerosing osteomyelitis. The bug. There's been some articles written. There's an oral surgeon did some research with this, and it's Eikenella corrodens. EICHINELLA. Eikenella corrodens is the name of the bug that's associated with ischemic osteomyelitis. When you see the condensing osteomyelitis, okay, you got to take that all out. Get down to where it's bleeding, and once you get to where it's bleeding, it'll heal. Those will be your worst patients, I guarantee it. They've been my worst nightmares. Their calcium and phosphorus ratio is all screwed up. They have poor circulation. And Weston Price and Dr. Page knew this years ago.
Lowered immune system, too.
Yeah, oh, sure. They're a mess. Chris?
I had a couple good results with the patients when I injected DMPS, EDTA, DMSO combination.
Sure. Yeah. Fantastic. And you cured it? You went into the bone? That's great. Let me just throw one thing in. I agree. That's why I started using it. The DMSO helps circulation both on flaps and your bone. That's why you use it. It improves blood flow. Plastic surgeons know that trick. They'll do tissue expansions with DMSO. You have to be careful when you do. I just want to throw one thing in here with the intraosseous injections. We have a problem with ischemia and lack of blood flow, and there's confined volume. Don't put too much fluid into there because you'll stop the blood flow. Be ginger about that, and use DMSO if you can. Be real careful about intraosseous injections. Don't use a lot of fluid. Yes?
Big question about HBO.
Yes.
What's your protocol on it, and does the insurance cover it, and where do you have your machine?
I'm in Reno. I usually don't take insurance. When I get my car fixed, the guy says, "Do you have an insurance card if I buy a loaf of bread?" You know, so that's the way I work. I've been in school for 20 years, and now it's my turn. You know,
well, we have an HBO machine in Mexico that we're using.
I will tell you that
and
the person
that's
to
why
see.
I'm asking about the protocol.
I'll tell you the protocol later on. Okay. You have to start carefully and work your way up. Yes.
Wisdom teeth, you mentioned whether impacted or always infected.
Yes.
But when they come out and erupt normally, you bother with them, or?
Yeah. First of all, you put your finger on, you go back in there, and on the lower aspect, you go lingually and you push, and the patient comes out of the chair. There's always bacteria in there. Jerry, how do you know? Jerry and I have talked about this for a couple of years. We don't know why. Maybe it's because when it erupts, it erupts slowly, and there's always bacterial traps in there, or that area of the jawbone is like a big filter anyway, and it catches bacteria from elsewhere. Who knows? But you know, always do neurotherapy on the area, palpate it, biopsy it. You won't be disappointed. Any other questions? If not, if you have more questions, get me later. Don, why don't you come on up? Dieter, why don't you introduce Don, please? Thank you. What? Take 2 minutes. Stand up.
I promise you, that was a great lecture.
Analytical technologies.
I promise you won't suffer through this lecture. Don is one of the greatest entertaining lecturers I've ever heard. And he's Australian.
All right.
And, he's actually the little brother of Crocodile Dundee. Let me tell you a little bit about Don while you're standing there.